Good evening, everybody. We're going to get started in just about 1 minute. I think while people are joining, we'll just get through some of the housekeeping. So we're really excited to have two esteemed speakers talk on assessing myotomy during Heller. So the learning objectives for tonight are to identify the best methods and techniques for evaluating the adequacy and completeness of myotomy during Heller myotomy. Also to describe key indicators and criteria used to determine the success of a myotomy, and explore advanced imaging modalities and intraoperative tools that can assist in assessing the completeness of myotomy. Now, this is accredited. There are CMEs available for this. And this activity is designed for advanced learners, surgeons, fellows, residents, and also extended healthcare providers and experts with at least a third of their clinical and research activities within the field of foregut. And novice and intermediate learners will have interest in furthering their education with foregut disorders as well. And the goal is designed to address patient care, medical knowledge, employee, evidence-based practice, interprofessional collaboration, communication. And this activity is being provided independent of industry support. I mentioned the learning objectives. There are a couple other ones as well, discussing, for example, workup and treatment of dysphagia after myotomy, and also discussing instances where a myotomy might be tailored for a specific patient. And disclosures you can see here. We'll leave it up for just a second. Okay, so I'd like to introduce our first speaker, and I don't think either speaker really needs an introduction. I think both are world-famous surgeons of the foregut. Everybody knows who they are, but John Gold will start. You know, he's not just an MD, he has an MBA. He's a tenured professor of surgery and chief of the Division of Minimally Invasive and Gastrointestinal Surgery at the Medical College of Wisconsin. He holds the Alonzo Walker Endowed Chair in General Surgery, serves as the Vice Chair of Quality in the Department of Surgery, and is the Froedtert and ThedaCare Health System Associate Chief Quality and Safety Officer. We all know him. He's nationally renowned. He's a foregut and bariatric surgeon. He's on the editorial board of several major surgical journals, including Annals of Surgery, Journal of Gastrointestinal Surgery. He serves as the associate editor for the Mastery of Surgery 7th and 8th editions, and he's authored over 200 peer-reviewed journal articles and book chapters. He also recently received the Leighton Rickers Master Clinician Award in recognition of his clinical contributions and leadership in GI surgery from SSAT. And we're very lucky that he has given us time to be here tonight to talk about how he performs a Heller myotomy and what modalities he uses to ensure adequacy and success. So John, thank you for being here. There are a lot of people that have registered for this event. We look forward to hearing what you have to say. Thank you.
Thanks, Mike, and thanks for having me. It's always awkward listening to your clinical bio read word for word. I'm going to add some walk-up music to it next time. We'll work on that. All right. So, as Mike said, we don't want this to be just us talking to the audience. We don't want this to be too pre-scripted. So, in that spirit, I've just grabbed a couple slides off of a talk I already had, and we're going to sort of start off with some of these. Try and cover these objectives, and we'll get to all the stuff that we've promised here as we go along. So bear with me. So I wanted to talk a little bit about the old way of assessing the myotomy um, following Heller myotomy or POEM or whatever it is. So what we've done historically, what I've done historically, is endoscopy is a really useful tool during myotomy for achalasia. And so here's an endoscope of a patient with a particularly dilated esophagus full of stuff that's draining poorly. So endoscopy is super useful during Heller for determining and assisting with the determination that the myotomy has been complete. So I like to do a endoscopy at the beginning of the case, just get a sense of how tight things are, what things look like, and then do endoscopy frequently throughout the case. And when you're doing it before the case, you'll often notice that, again, there's secretions or food in the esophagus. It can be hard to traverse the esophagogastric junction because there's resistance. When you get through and you retroflex the scope, oftentimes you'll see the mucosa grabbing the scope. If you're retroflexed and you're sort of moving the scope inside and out, you can sort of roll the squamocolumnar junction in and out because it's hanging onto the scope super tight. And you want to see that that's changed when you feel like you've completed the myotomy. So you want to see a little gap between the mucosa and the scope. You want to get through with less resistance. You want to park yourself right at the esophagogastric junction and see that without insufflation, that you got some space to see into the stomach. And you can use the endoscope to determine how far you've gone onto the stomach. I think it's important to make sure that you have. I do a fair amount of reoperative surgery for failed myotomies, and oftentimes the case is that the myotomy just never made it onto the stomach by enough. And so doing the endoscopy can really confirm that for you. And so just wanted to sort of show real quickly a video on the bottom of how you can do that. So with the robot, we're sort of assessing where we are relative to the esophagogastric junction. This is sort of parking at the esophagogastric junction without insufflation. You can see how loose that is. And this is an image from an endoflip, which to me is the new way to assess whether the myotomy is complete. And so for those of you that aren't familiar with endoflip, this is a technology that's been around for a while. It's an endoscopic functional luminal imaging probe, and this uses impedance planimetry to assess the distensibility of a hollow structure. So that this involves an infinitely compliant balloon with 16 electrodes at 5 mm intervals, and this can assess the cross-sectional diameter of this luminal structure. It will measure the pressure within the balloon. You do a volume controlled distension, so you control the volume, and you can determine a variety of things. One of the most useful measures in achalasia surgery and myotomy is the distensibility index, which is a calculated measure based on the diameter at the waist, which is you put the waist of the balloon at the esophagogastric junction where the lower esophageal sphincter is. So that diameter divided by the pressure in the balloon gives you a distensibility index. So a highly distensible structure will open at low pressures. A poorly distensible structure, which is the LES prior to the myotomy, takes a lot of pressure to open that up. You'll have a really low distensibility index. And so we like to measure it before the myotomy. We often get very low numbers, and then after, and we use this to determine whether we feel like we've done a good enough job. And the endoflip is a really intriguing technology. There's a lot of conversation as people learn more about it, about whether this can replace manometry. That's still an ongoing dialogue. I imagine we'll get into that at some point. But basically, manometry is still the gold standard. Let me get everybody's face off of here. There we go. But there are some things that you can see on the end of flip catheter in the OR from a motility perspective that can be helpful and consistent with achalasia. I mean, you want to know that that's the diagnosis in advance. Min's going to share a couple case stories about where the endoflip is particularly useful in determining if dysphagia and elevated IRP and all these other things are related to either a paraesophageal hernia or to achalasia. So he's got a couple cases he's going to share with us, but this can be useful in some cases in defining the diagnosis. And you can see something that's called repetitive retrograde contractions, which are diagnostic or consistent with achalasia. And so when you put this balloon across the LES and you distend it, it can induce contractions in the esophagus. Repetitive antegrade contractions are frequently induced in patients with normal peristalsis, and this is a secondary peristaltic response to distension of the balloon. And so with the endoflip machine, you can see the time axis sort of flowing, and you can see the antegrade direction of these contractions, and those are normal phenomena. Repetitive retrograde contractions are these contractions in reverse. And if you see 3 of those in a row, that's pretty characteristically seen in patients with spastic disorders and type 3 achalasia, especially. This is just a study that sort of shows that. This is the endoflip using to detect contractility not observed in manometry and achalasia patients. And you can see normal patients on the left, type 1 achalasia, type 2 achalasia, type 3 achalasia. And these RRCs, repetitive retrograde contractions, is that sort of darker gray box on the right, where 80% of these 10 patients with type 3 achalasia in this particular study were able to induce repetitive retrograde contractions at the time of endoflip. Endoflip is especially useful. I think it's less useful for diagnostic purposes. It's especially useful in the OR. And so there's lots of stuff out there. Mike has published much of it. But I'll just share a few key studies. This is looking at the distensibility index post-treatment and how it correlates with time barium esophagram and the time it takes to empty on that study. And you can see that the distensibility index has a direct correlation. Changes in the distensibility correlate with the outcomes in achalasia patient. This is on the right is a graph of the change in distensibility as it relates to the highest postoperative Eckert score. So you want a low score. That's one of the ways we assess the outcome is with this metric called the Eckert score, this validated instrument. A low number is better. Less than 3 is often considered clinical success. And you can see that the changes in the distensibility index are correlated with achieving a really low Eckert score. And this is, again, Mike's study with 2-year follow-up. More stuff from Mike looking at the percent of patients with a postoperative Eckert score greater than 3 as it relates to the final distensibility index. So just the absolute number, and 3.1 is a number for the distensibility index that is often used. I use 3. And you want to get that over 3 during the myotomy. And when you're able to do that, you can see that the chance of you having an Eckert score that is associated with a good outcome is better. And let's see here. This is in Poem. So the downside of the myotomy, and part of the reason we'll talk about tailoring the myotomy, is not only is it safer and more expedient to limit the myotomy to all that you need to be effective, but in Poem in particular, where you can't readily do a fundoplication, a really high distensibility indexes have been associated with a greater incidence of esophagitis. And I imagine we'll talk about that some more. And I wanted to wrap up the didactic portion of what I was going to talk about by just talking about endoflip guided myotomy and from a practical perspective. How do I use it? What are my tips? Well, I like to assess the distensibility pre and post myotomy, as I was talking about. You'll see really low numbers, and as I shared earlier, there is some good data to show that the change in distensibility as well as the absolute distensibility index are correlated with outcomes. So I want to know where we start. I shoot for a distensibility index that's greater than 3, or a change of greater than 3, or a minimum diameter at that waist at 40 mLs or more than 10 mLs. And usually you'll see all of these things at the same time in a patient who's had an adequate myotomy. And as long as we're talking practical tips, avoid passing the catheter blindly from proximal to distal. So I've learned that the hard way. I imagine some of us on this webinar have as well. The tip can be a little stiff, and if you pass it blindly, especially if the esophagus is dilated or beginning to get a little curved or sigmoid shape, that can go through the myotomy pretty quick before you realize. And so what I do, ideally, if the catheter is already in the stomach, you just pull it back. Oftentimes you need to remove it to recalibrate it. And so if you're passing it again after the myotomy, I get the scope all the way down. I use my finger to guide the endoflip catheter past the hypopharynx, so I know it's in the esophagus, about 25 centimeters or more in. Then I hold the flip catheter, pull the scope back until I can see the catheter right in front of the scope. And then I just drive them right down together, making sure that I'm centered. I'm not going to push that through. And then if there's a mucosal perforation and it's repaired, and one of those repairs you're a little concerned about, especially if you already have done your distensibility and have a pretty good sense about where you're at. I tend not to repeat the endoflip. I worry a little bit about the distension messing with your repair. And that's another thing I think I learned the hard way a number of years ago. But those are some practical tips. And I will stop talking and sharing. Let Mike take over.
Yeah, John, that was excellent. I'm going to, I guess one thing is just to humble you, John. If there's one negative, I've known John for many years. So one negative, he's a big Packers fan. So I forgot to mention that. But I want to bring in our next panelist, Dr. Min Kim, again, somebody who needs no introduction. If you don't know him, Dr. Kim is currently the vice chair of the Department of Surgery and head of the Division of Thoracic Surgery, and the David Underwood Distinguished Professor of Surgery at Houston Methodist Hospital in Texas. He completed his medical school training at Johns Hopkins, and he completed his residency at Beth Israel Deaconess Medical Center, and did his thoracic fellowship at the University of Texas MD Anderson, where he completed his training in cardiothoracic surgery. Obviously, he is an expert in thoracic surgery, esophageal and lung surgery. He focuses on both benign as well as malignant disease of the esophagus and the lung. And Dr. Kim was a very early adopter of impedance splenimetry or endoflip. And so he has a pretty vast experience with not just Heller myotomy, but also endoflips. And so, Min, I wanted to ask you a little bit. We just heard John's talk, and which was outstanding. Is there any advice that you would give? Do you use endoflip regularly during Heller myotomy? And if you do, how do you use it? What are you looking for? Are you looking for similar ranges of numbers that he is? Do you have any pearls on how to do a safe and effective Heller myotomy, and any pearls on how to use impedance splenimetry during the case?
Sure. And John, that was a fantastic talk and great introduction about using the endoflip. I've been using endoflip for a very long time, and I think now I think we're close to like doing over 1,200 kind of cases, foregut cases using the endoflip. And I feel like for treatment of achalasia, especially doing Heller myotomy and fundoplication, I feel like this is something that it's a must for our patients. Ever since I've been using it, I no longer worry about the patient next day. I leave the OR knowing I did the right operation for the patient, and then I did the adequate amount of the operation, meaning adequate myotomy, and I didn't make my fundoplication too tight. And there's no comfort for the surgeon. I mean, all of us hate going back, right? Or having an issue like, and wondering, do we make this too tight, or did I do this adequate myotomy? The way I approach it is that I like to place the endoflip at the beginning of the case. So after I dock my robot, I'm looking at the G junction, and then I place the endoflip. If it doesn't go very well, then I do the EGD to exactly what John said, to kind of advance it. The reason I do it in the beginning is that then I don't have to worry about potentially perforating the the myotomy, I mean the mucosa with the endoflip device. And then I do my standard myotomy, and then I basically check. And the beauty is that once you do the myotomy and then you check, and if the numbers look good, and my numbers are pretty similar to John and Mike, your numbers, then I don't have to do any more, right? Because then I know the myotomy is adequate. And then I do I do door fundiplication. And once I do the door fundiplication, you kind of want to make sure that it's not too tight. So if your DI is below 1, then you want to modify that, because you kind of made your fundiplication way too tight. So when I leave the operating room, I know that the myotomy is adequate, and then I also know that the fundiplication is not too tight. And I think that makes a huge difference for our patients.
One question I want to ask both of you is how do you perform your myotomy? Meaning, what kind of energy are you using? Because monopolar energy with the balloon catheter in place can affect the the tonicity of that hypertonic solution. And so we use bipolar energy. So whether it be bipolar scissors, for example, or some other devices out there. And so I'm just wondering if you've had the same experience, because I think every time I've tried to use monopolar energy with the catheter in place, it's kind of messed up the catheter, and it's become not usable. And I guess the other question I would ask you is, do you have the catheter inflated at all while you're doing the myotomy? I've found that kind of useful, actually, where I can actually in real time look over, and as I'm doing the myotomy, and see the distensibility increasing to that level that we like to see around 3. And so I'm just wondering if you do the same. I don't think you have to do it that way. I think you can just check it after you're done with your myotomy. But I also think that having that balloon catheter inflated actually helps you see the fibers better. But that's just anecdotal in how I feel. But I'm just curious, what energy do you guys use? How do you cut the muscle fibers? And do you ever use an inflated balloon during myotomy?
Mike, I was just gonna, like, you answered a question I was about to ask. So I used to leave it in, and I've started to pull it out entirely, because I found that when I go back to check the distensibility, it often doesn't work. So I didn't realize that was the reason. So I'm learning something here.
Yeah.
Yeah, so I take it out, because half the time you go back in, and for whatever reason, the pressure is all messed up, and you can't calculate an index, and it's just completely wonky. So I've been taking it out and doing what I described, um, and I use monopolar cautery. It's just what I've always done. I hadn't seen that issue with it. And since I'm talking, I don't do it with the balloon catheter distended, because I take it out.
Min, how about you?
So I use harmonic, and the reason for doing harmonic is that that's how I learned it with the laparoscopic, and then when I transitioned over to robot, harmonic works really well for us. And harmonic has no impact on having issues with the endoflip. And what I do is that I mean, after I do my myotomy, and I want to see if it's adequate, and if it's below 3, then I leave it on, meaning leave it distended, and look for those little fibers. And it's very helpful, like you said, that you can actually see those little fibers that's inadequate. And once you release it and you look at the number, and you're like, wow, okay. And I probably have left that patient and left that OR leaving those fibers if I didn't have this device. So that's the kind of the real intra-op use of this device, which made clinical change for my patients, I think.
Excellent. There are questions that are starting to come in, and I want to address a couple. So one question, actually, Min, I think you actually have a case that's perfect. Somebody asked about the odd case of esophagogastric junction outflow obstruction, or EGJOO, and the use of endoflip to confirm the diagnosis. So I think perfect timing. If you have that case available, do you mind bringing it up?
Sure. And like I said, that the reason I use endoflip is that adequate myotomy and adequate fundiplication. But the other answer is that other thing that I want to make sure for the patient is that I'm doing the right operation, right? And all of us had this issue where you kind of see a patient, and I'm going to present the case, and then we can kind of talk about it. So you see a patient like this. So this is 57-year-old female who comes in with a history of reflux. So her reflux has been going on for 15 years, symptoms worsened by spicy food, heartburn, and she now has breakthrough symptoms on pertonics, and she has some anemia. And then you do a questionnaire. All my patients have questionnaire. She scores 19, which is pretty bad. And then this is her past medical history. So I see her, and then on EGD, they see a hiatal hernia, and they're saying it's a small hernia, but it might be causing some gastritis or anemia. And this is her esophagram. On her esophagram, the contrast flows very well. She has a small hernia here, but no signs of dysphagia and no history of dysphagia. But you send her for a manometry, and this is what we get. IRP of 19.4, normal peristalsis, EGJ outflow obstruction. So the question is that, we all had patients with reflux with achalasia, or symptoms of reflux, surely not reflux, but achalasia. So what do you do in this case? And this is her Demeester score, but the good symptom correlation with the heartburn. So the question is that, are you going to do Heller-Dor for this patient because of elevated IRP, or are you going to repair the hiatal hernia and do a toupee? And for the symptom-wise, I mean, you should do the hiatal hernia and toupee, but based on the IRP, you should do a Heller-Dor. So we took her to the OR, and what I told her that we're going to do the endoflip. So this is the endoflip. When I place the device at the beginning of the case with the hiatal hernia, it's still there. And you can see that DI is 0.3. This is very, very tight at GE junction. And then the question again, what should we do? But what I do is that I go by the measurement after you mobilize the hiatus. So what I did was basically took care of the hiatal hernia, brought the stomach below the diaphragm, have the 3 centimeter of the esophagus, and then measure her endoflip values, and her DI is 2.3. At this point, this is consistent with her symptomatology. So we did the hiatal hernia with toupee from the vacation. This is after mobilization, closure of the cruise, and then the door. I mean, this is a toupee from the vacation for the patient. So, and then 30 days later, she comes back. She's off pertonics. Her symptoms are much better, and she said she was so happy. A 10 out of 10 symptom improvement. So this is a type of case where I feel like without the endoflip, I'm not sure which operation I would have done for the patient. And I feel like this is the right operation because the patient had a good outcome.
And what if the after you reduced the hernia and you measured the DI, what if it was still low? Would you just go ahead and perform a myotomy? Do you have that conversation with the patient beforehand? Again, it seems we don't like to come back to the OR. So
Exactly.
and we don't like to just take her to take, and we can't really get an endoflip reading in the GI lab or somewhere else prior to the OR, because really we need to reduce that hernia, because it's really probably the hernia and the distortion of the anatomy that's causing that manometry catheter to read a high IRP, correct? So, but in some instances, and I think it's happened to all of us, there truly is EGJOO. So are you preparing that patient for a possible myotomy?
I do, and I talk to the patient about both possibilities. I say most likely it's going to be this, but we might do this based on what we see in intra-op. And I think that's the beauty of it. And I haven't had to do that once I reduced, and then you still have that tight G junction, and then we would do a Heller-Dor in that case.
Excellent. Yeah, and I think what's important for the audience to know is that only 5% of the normal population will have a distensibility less than 2. So if you are in this situation and, you go into the operating room, you reduce the hernia, and the distensibility is still less than 2, it's 1 or something like that, that probably then is 95% that's going to be EGJOO, and you probably should just do a myotomy in addition to fixing the hiatal hernia and doing a fundoplication. I don't think that will happen very often, but it still can, it can happen. And I think endoflip has really made it much better to deal with these situations in these patients. So I think that's a great case, and I hope that answers that question. There's another question about, maybe I think going through the protocol a little bit. So somebody asked about, do you do endoflip before the myotomy? Do you measure the DI using endoflip before or after hiatal dissection? Can you, John, maybe talk a little bit about when I think you mentioned it, but maybe just repeat, like, when do you take your measurements and what are you doing with those numbers?
Yeah. No, I do it before I do anything. So patients asleep, they're positioned before I put ports in or insufflate. I get the catheter across, um, and I assess it. So I'm looking to see where it's at in the beginning. I'm interested in the change, the delta in the DI, and whether I can get over 3. So I check it again when I feel like I've completed the myotomy, or if I feel like I might have completed the myotomy. It's sort of my little check-in to see how I've done. Um, it can be hard sometimes if the esophagus is really dilated and sort of hooked at the end. You wind up with the catheter sort of poking against one wall, and if you can sort of trap the catheter tip against the wall of the esophagus with the scope, you can often drag it in. Occasionally, I just can't do that, but I like to get it both.
And I think just to be clear with the audience, we just showed a case that has to do with reflux and possibly EGJOO. It turned out not to be, but really the presentation's been focusing on Heller myotomy. So when we talk about hiatal dissection, in general, how much hiatal dissection are you doing? So if somebody has achalasia, are you doing 360 degrees of hiatal dissection, or are you just doing like the anterior? Min, what do you do? And then John, I'd hear from both of you.
I do anterior because
Yeah.
I feel like I don't like to do the posterior dissection for patients with a pure achalasia, because I think this really kind of help. And most patients don't have a concomitant big hydrohernia.
Right.
And yeah, so basically it's a simple anterior dissection, and that's why I do a door fundoplication.
John, are you the same? Do you do mostly door or toupee after a Heller myotomy? Which do you choose and why?
So almost all door for me. I do a little more of a dissection. It's not the up to the aortic arch, inferior pulmonary vein kind of stuff. I do go into the mediastinum circumferentially, partly because I want to make sure that the doors on the esophagus, that I have enough intra-abdominal length to feel like I've done that right. So I want to see 3 to 4 centimeters in there. Um, and I really don't do toupees. The last time I did it, I mean, not for achalasia when I'm doing a myotomy, I do them otherwise constantly. But the last time I did a toupee and a Heller was I had a little too much length on the esophagus. I like to fix the door to the diaphragm, the left and the right crural pillars, as well as the edges of the myotomy. And I felt like the door, when I got it sitting right, was still so far away from the esophagus. When I pulled it up, I felt like I was sort of kinking or angulating the esophagus. So I did a toupee in that person, but I'd rather do a door. I think it's just a little more straightforward.
Yeah, I think that uh, there are some patients that have achalasia with a hiatal hernia or EGJOO, and I think if in those cases you're going to have to do a full 360-degree, dissection. But I think most people would probably also agree with you guys that you don't need to do that length of a dissection, and probably shouldn't, because maybe risking the recurrence risking recurrence later, the more dissection you do, and recurrence after a Heller myotomy and a door fundoplication can be kind of a pain. But I think there are times where if there's a hiatal hernia, you just have to do it. And I think that probably most would agree that you don't have to do a full dissection if there's no hiatal hernia, which is the majority of patients. And I think the randomized trials have not showed a major difference between door and toupee, although if you look closely at those studies, if they were powered correctly, toupee probably does have an advantage over door when it comes to reflux control after Heller myotomy. But a door seems to absolutely be adequate. What about protocol? One person is asking about whether or not you change the patient position to supine. Do you reduce insufflation? Like, what's your protocol there? Min, why don't you answer that first?
Yeah, so I do robot for I use the robot for the Heller myotomy and door fundoplication. So it's really challenging to position change the position of the bed when you have the robot completely docked, unless you undock and all that stuff. So for efficacy, I've kind of made the patient and reverse Trendelenburg at 25 degrees. And I've been able to leave the insufflation on and get the relative values for the patients, right? So I know you have a beautiful paper about getting rid of the insufflation and you get better values, right? And then I think that's probably the best way to do it. But I've been able to get, I mean, all you want to know is that you look at the endoflip balloon and see if your minimal diameter is greater than 10 and then your DI is really greater than 3, you're pretty set in terms of you're not gonna get any big differences if you change the position. So I just leave reverse Trendelenburg at 25, insufflation at 15, and then do the measurements, and then you can see the differences between after myotomy and after the fundoplication.
Yeah, I want to clarify that I don't think that decreasing insufflation and then getting your numbers is better. But the reason that we recommended it in our first white paper was because we wanted the numbers to correlate with our GI colleagues who are measuring it in the GI lab where there's no insufflation. So it's not that one is the better, but we just have to make sure that when we're reading our papers and when we're interpreting the results, that insufflation does make a difference. Insufflation will decrease the distensibility, and that's a simple fact. And so, if we're looking for a distensibility of 3 without insufflation, then probably a distensibility of 2.5 with insufflation is about the same. And so I just think everybody just has to keep that in mind. And then when it comes to supine versus like reverse Trendelenburg, actually that doesn't have an effect on the distensibility. It inversely affects the cross-sectional area and the pressure inversely so that the distensibility winds up being the same. So you don't have to worry about position changes if you're just looking at distensibility. And so I think you can use whatever protocol you want, whether or not that's keeping somebody reverse or flat, that doesn't matter. You definitely don't have to move the table. You can leave the table where it is. And then John Lipham has said that they have gone to leaving the catheter in, but unplugging it from the machine to avoid the issue of energy, which is also a good idea. Yeah. So I think those are good tips for people to hear, as how to use it. I want to ask you both another question about tailoring your myotomy. Is your myotomy always the same length? And what length is it? Or do you change the length of your myotomy and why? And then also, if you could focus on what length are you doing a myotomy on the stomach? John, do you want to start with that?
Sure. No, I for primary myotomies, we're usually doing about 6 proximal and onto the stomach by 2, which that I make that sound like that's very specific. It is hard to know when you're 1.5, when you're 2, when you're 2.5. So I do 2 confident 2, which is probably 2.5. And then we'll do a endoflip and see where the numbers are at. And if it's not where I think it needs to be, I'll go a little further or start looking for any areas where I may have missed it or where things are scarred. I do that pretty consistently. On some of the revisions where there's already a myotomy there, I might adjust that, especially if it's like a poem after a Heller. Type 3, I treat that differently. I think we all do. You're trying to max out the myotomy as high as you can. Same distance onto the stomach, but that's sort of my approach.
Min, how about you?
Yeah, I do the same. I do 6 centimeters on the esophagus and 2 centimeters on the stomach, and then I check the endoflip. So that's my kind of standard. And then if the endoflip shows that it's not adequate, then I might go a little bit longer on the stomach side usually. Esophageal side, I never had an issue after about 6 centimeters, but the question is that should I go a little bit more on the stomach? And the endoflip's been very helpful in that.
Do you do anything differently for type 3 patients, the spastic achalasia patients?
I mean, so those patients usually POEM, right? It probably is a better operation for that group of patients. And I try to go longer on the esophageal side if for some reason, we're doing a Heller.
Yeah.
Okay.
And do either of you ever operate on jackhammer esophagus, for example, or distal esophageal spasm?
Not to.
I have not.
I
Okay.
should try not to.
Yeah.
Send them thoracic surgeons like men and see what happens.
And
I
then
get-
how do you determine, so you've done your myotomy, you've got a good DI of 3.5. How do you really determine though ultimately the success of your procedure? Are you looking at them clinically? Do you get any studies postoperatively? How do you determine the success of a Heller myotomy, John?
Uh, we do the Eckhart score before and after. We have a variety of questionnaires. We administer GI quality of life, GERD, HRQL, stuff like that. So we're looking for an Eckhart score less than 3. We're looking to see that the patient feels like they had a good outcome. Like it's pretty obvious usually that this is my favorite operation to do, not only because it's fun and technically challenging, but patients know that you help them right away. It's very satisfying. So we do that, and then I have most of my patients come from a couple different GI groups, and they both like to get those patients back and do an endoscopy at 6 months, and so I have them do that. But I'm part of I get CC'd, and we continue to follow those people with our GI colleagues for a while, depending on what they had.
Min?
Yeah, we do something similar. I mean, we have questionnaires. We have 3 questionnaires: Eckhart score, obviously, and then accolade dysphagia scores. I mean, it's dysphagia questionnaire, and then the GERD HQR questionnaire. And then we do that at 5 weeks, and then we bring them back every year, and then do the questionnaire. And then if things are bad, then we will do an esophagram. So we've been trying to follow these patients for longer term, just so that we can kind of understand how they do.
Now, reflux rates are not 0, even with a toupee or door fundoplication. How do you assess whether or not a patient may have developed reflux? As we probably all know, achalasia patients don't often feel reflux until it's too late, until there's a stricture. I mean, that's a very common scenario, right? A patient comes to you postoperatively, I'm doing great, I can swallow again, thank you so much. A year later, my achalasia is back. Well, you do an endoscopy, it's not really back, there's a stricture there or bad esophagitis. So tell me each your protocol. Do you leave patients on a PPI postoperatively or not? Do you routinely test them with a pH probe at some point postoperatively, or do you just follow them clinically for reflux? John, what do you do for reflux, or do you just allow the GI colleagues to make that decision and let them work them up for that?
So for the Heller patients who have a fundoplication, we'll taper and stop, and then we'll get the endoscopy at 6 months. And if there's any signs of esophagitis, we'll put them on a PPI, maybe check a pH study. We'll treat those patients differently. As you mentioned, symptoms aren't always the best indicator of pathologic reflux in this cohort of patients. For the poems, we keep them on a PPI, and then we assess a pH study at 6 months off the PPI and go from there.
So you feel that the reflux rates are low enough after a fundoplication, you don't need to routinely get a pH test. That's fair.
Yeah.
Min, how about
Yeah.
you?
Yeah, no, if for the yeah, what we do is that we do the questionnaire. So we kind of do that 5 weeks and every year, and that GERD questionnaire, if that's positive, then we would investigate. We'll start with an esophagram, and then we'll kind of follow up with further studies. But the rates of reflux is very low after clinical reflux, all right?
Yeah.
And it's pretty amazing that if you do the questionnaire, 60% of the patients, or up to 70% of patients, will complain of reflux symptoms with achalasia. All right. So, and if 5 weeks later, all of those symptoms go away after the adequate operation.
Mhm.
So,
Trip Buckley, who we all know, and mentioned something in a chat here that when it comes to tailoring the myotomy, actually EndoFlip is a great tool to do that, because if you leave it in and you leave it inflated while you're doing your myotomy, you may not even need to do 6 centimeters or 2 or all that. You may be able to do less of a myotomy, and because it'll kind of tell you when you've completely opened the LES. And I think that's a really good point. And I think something that everybody should consider if you're using EndoFlip regularly, consider using, energy like harmonic or bipolar that's not going to affect the 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 voltage within the balloon catheter. And, you can literally look over at the screen in real time and just, see as you're, doing the myotomy and just stop when you've gotten to your goal, which I think we all agree is about, 3 with desufflation. So I thought that was a good point. Another question, how do you deal with, and Min, we'll start with you, patients had either a poem or a Heller myotomy with a door, you choose, doing great, kind of doing so well, kind of disappears for 3 years and all of a sudden comes back. So hasn't been following up with your 1-year protocol, comes back 3 years later with dysphagia. Tell me how you work that patient up.
Yeah, I think first thing I always do is start with a time barium esophagram. I think that kind of gives you a lot of information about what's going on, and you can kind of tailor your treatment plan based on what you see. And then probably if there's a concern, there's something going on at the GE junction, probably endoscopy with endoflip. And I think that can kind of give you a lot of information at that time. And if you need additional testing, maybe manometry. But I think those are the 2 things that we do for now.
John?
Yeah, same thing. Time barium esophagram and an endoscopy, work from the differential from there. If there's a concern that what's interesting to me is how patients can have Heller and feel okay for a while and then come back and it's an incomplete myotomy on a manometry. So we do that. Our manometry lab, our gastroenterologists like to do a lot of pharmacologic challenges to tell us if there's a portion of the LES that's intact. So it sort of depends. We have a stepwise approach to addressing this.
So, Dr. Lipham, it brings up the case where it looks like myotomy has been completed, but the DI or the distensibility index really hasn't changed much or is still low. And then there are some, with the balloon inflated, you can kind of see these fibrous bands that once you then cut those, all of a sudden the DI becomes normal. Is that something that you guys have seen? I know I have absolutely seen that, and it's made me so grateful that I've had EndoFlip available, because I probably would have left the operating room if all I had were my eyes looking at it. Have you guys seen the same thing, Min?
Yeah.
100%. Yeah, like I mean, and that's the beauty of, when I say that I leave the operating room knowing patients will be fine, it's because of exactly that. Because before EndoFlip, 100% I would have left, and I would have left those fibers. Next morning, it would have some still dysphagia, and then I would like, did I do the right thing? But with EndoFlip, I inflate it and I see those fibers and DI is kind of low. You cut it and then it's beautiful. So.
Yeah. And I'm not like, I don't use the flip during the myotomy. So the corollary for me is the patient with the scarred muscle where you cut it and it doesn't really pop open. And I want to see that the myotomy spreads open widely. So someone like that, I'm going to lift up that edge and you'll see those same fibers. Or I'll do a flip and then I'm not happy with that number. And you'll lift up the muscle edge and you'll start to chip that stuff away and you'll check again and it looks a lot better. It's either you haven't gone far enough or if you've really struggled in the first place because there's so much scarring, a lot of times you just need to spend a little time busting those bands up.
So we're clearly talking about how much we rely on impedance splenimetry intraoperatively during these cases, but Dr. Dunn asks a good question. Well, what if you don't have it? What are you doing, for example, in the case that you presented, Min? What would you do, or what did you do before you had impedance splenimetry in the operating room? What do we do in that situation where somebody comes in with a 3-centimeter hiatal hernia, classic GERD symptoms, and then all of a sudden the pre-op manometry shows EGJOO? What is your recommendation to people that don't have impedance splenimetry in the operating room?
I think it would be really hard for me. Well, before I had EndoFlip, what would I have done? I think I would have reduced everything. I would have done an EGD and try to make an assessment or best clinical guess for this patient. And with her preoperative symptomatology, I'll probably end up doing either door potentially, right, instead of a toupee, just because I'm a little bit worried, right? And then, but I would leave the operating room wondering to myself, did I do the right operation?
John, how
I
about
think
you? What's your
I think
recommendation?
yeah, I think the latest iteration of the Chicago classifications provided a little guidance, 4.0. So egg juice, one of these things, like it's just been this enigma. I think in a patient with mildly elevated IRP who doesn't have dysphagia, probably it doesn't matter. Like I would ignore that. If a patient has dysphagia, I think a time barium esophagram can be extremely helpful preoperatively. So if they have prompt emptying and mild elevation, I'm trending towards this is more GERD than an achalasia type picture. If they have delayed emptying and dysphagia and an elevated IRP, and I don't have endoflip, I'm probably going to treat that patient like they have achalasia.
Well, I think in answer to Colin, the question there is that, first of all, EGJOO diagnosis cannot be made without confirmation with either endoflip or a time barium esophagram. So the situation you're bringing up would only occur if a time barium esophagram had also shown, slow emptying, for example. So, I don't think you're going to go. You would work that up prior to the operating room, and if endoflip's not available at your institution, then it's a time barium esophagram. And if time barium esophagram is abnormal, you're probably going to do a myotomy as well as a hiatal hernia repair. If the time barium esophagram is normal, then you probably just need to reduce the hernia and not worry about a myotomy. But I would say my preference is endoflip over TBE or time barium esophagram. And because I'm going to use it no matter what. And I feel like endoflip is more accurate. Personally, I feel just that it's more accurate than a TBE, although they do correlate well with each other. So I don't want to say TBE is not good exam because they do have good correlation. But I think hopefully that answers your question. And then we have another question, which I think is similar to similar to what we talked about before, but a patient with achalasia who had a pneumatic dilation 10 years ago that was successful. The patient really has had no dysphagia since that time, but now is coming to you with reflux symptoms that's getting worse with time. An endoscopy is performed, no resistance. The esophagram looks like it's emptying okay. There's no bird's beak or hang up. If you operate on the patient who's had a pneumatic dilation, or let's say even a POEM for reflux, would you do more of a myotomy if the manometry has been acceptable already? Would you use impedance planimetry in the operating room to maybe even answer that question as well? I guess the question is, while you're there, should you also do a myotomy, even though there's really nothing showing you preoperatively that you need to? Min?
Yeah, I actually had that case 2 weeks ago, or actually 3 weeks ago. We ended up, the manometry was completely normal. A patient had a POEM previously, and the manometry showed that the IRP was normal. Time barium showed that prompt emptying. I did use the endoflip at the time of surgery because I wanted to make sure that I didn't make him too tight, because this guy was very, very happy except severe reflux, meaning he can eat whatever he wants. And I didn't want to lose that. So we ended up using the endoflip to kind of get the baseline of how he was at that time. And then with the door fundoplication, I just want to make sure that your DI wasn't too tight for the patient. And he doesn't not have any reflux, and he's off of his PPI. So very successful.
Exactly.
John? Same thing.
Exactly. Yeah, you got the tool, or at least we do. I would use it. But no, like if you don't have it, if the case you describe, normal emptying, manometry, IRP is normal, I would just fix his reflux and be very careful about treating him like an achalasia patient who's had a myotomy, who's not going to have a lot of push.
Hey, I will say, and I was going to ask you guys this, and I will now, but before I used impedance planimetry regularly, I will tell you that I was always a bit nervous about how tight to close the crura, you know, which we, you know, should we even just leave it alone? I mean, you know, we didn't know the answer to that before. You know, we have a patient with achalasia, they have no peristalsis. We've, you know, we've opened up the crura a bit anteriorly, done a little dissection, and then you look at it and it looks open and it's a little bit nervous, you know, leaves me nervous to leave the OR like that. So you want to put a stitch or two in there, but you also don't want to do it too tightly. What do you guys do with the crura? Do you tighten it? Again, is EndoFlip something that is really helpful in order to making sure that you're not too tight? How do you address the crura during a Heller myotomy? John?
Definitely looser than any sort of foregut procedure. Like I'm trying to, like, if it's a GERD with normal motility, I want to close it so there's not compression of the esophagus, but really no big gap. I don't want the crura anywhere near the esophagus when I'm doing it for achalasia. Like I want to see a little space there, and I have to be very, like you said, like I always want to put one more in, and I just talk myself out of it. There's nothing worse than doing a good myotomy and screwing it up with one more stitch than you need.
Min?
Yeah, so for those cases where patient had a liver hydro hernia and then you did the posterior dissection, what I do is that I use the endoflip. I mean, obviously after myotomy and you're trying to decide whether how much to close, right? So I use the endoflip as a bougie. So I distended it. And what I do is I just try to close the esophagus just so that I'm not doing any compression. I just try to get rid of that space.
Crura, you close the crura, you mean?
Yeah, I'm sorry.
Yeah,
I close the crura so that there's
with the balloon inflated.
exactly.
Yeah,
And
probably about the same.
that just works beautifully because
Yeah.
you know that you're not making it too tight. And so that's how I do it.
Yeah, there's a really good question that I'm glad was brought up. How do you deal with achalasia and gastroparesis at the same time? And I think, you know, before I ask either of you to answer that, I want to bring up the fact that you have to be very careful interpreting a gastric emptying study in a patient with achalasia. Because remember that the way that that study works is that the nuclear medicine radiologist is bringing that patient back an hour or two and maybe 4 hours and 4 hours later. And if there is still retention in the stomach, is that because the stomach's not emptying, or is that because the food just got to the stomach because it's slow through the esophagus? So I think I am very reticent to interpret a gastric emptying study in a patient who certainly who has not been treated yet for their achalasia. So I want to bring that up. Min, John, can you give me your thoughts on, you know, gastroparesis? Because it certainly does, it's out there. I mean, there's no question. And because I've seen it in people who've had successful myotomies that then come back with clearly gastric emptying symptoms that are delayed. So what's your perspective on gastroparesis and achalasia in the same patient?
I personally treat the achalasia first, and then probably use kind of medication to help with the gastroparesis, like medical management first. And then, but if it's really a problem still after the myotomy and door, then I would probably refer a patient to the doing POP or something along those lines. But I don't like to treat both of them at the same time because of exactly what you said.
Yeah, I agree, and I'll just expand upon what you say, Mike. So the diagnosis of gastroparesis may have been made. I've seen it where radiologists let the computer tell them what the emptying is, and you know, if a patient, I've seen this especially in like VBGs and lap bands, they're looking at the pouch above the relative obstruction, and it can happen in the esophagus too if they're just letting the computer tell them what the counts are. So I like to look at the images, which, you know, they're real funny little speckled shapes, but you can sort of tell, is it actually in the stomach or something else? So I take that with a grain of salt. And the same thing, if they're doing a scope and they're finding food in the stomach, a lot of times that's food you blew in it was sitting in the esophagus, and they pushed or blew it in, and they see it in the stomach, and now they're telling you the patient has gastroparesis. So I think it's hard to make that diagnosis definitively in advance, and I would do exactly what Min said. I'd treat the achalasia, and if we needed to go back and do a GPOP, I'd do that later.
Before I think we're only gonna have time for one more question, but before I ask that, I just want to remind all of the listeners and participants that the AFS meeting is coming up next month. If you haven't been to the meeting, it's always a wonderful meeting. There are experts in the field, and just getting a room full of people that care about the foregut, and talking and hashing it out is a wonderful experience. I've always learned a lot at the meeting. So hopefully, if you're not registered yet, please do so as soon as you can. It'll be in a wonderful place as well. So, go to the website and register. One last question, and I think it's a good one from Dan Lister. What is your salvage procedure after somebody's had a successful Heller myotomy and then comes back and, or I shouldn't say successful, but somebody maybe comes to you, they've had a Heller myotomy somewhere else, they come back, the workup is clear that there's an incomplete myotomy. And I will tell you, in my experience, the most common scenario when somebody comes to me as a patient, they've had a previous Heller myotomy somewhere, and they have, manometric evidence of ongoing achalasia. I look at the op note, and almost 90% of the time, there was a perforation, a mucosal perforation, and I'm sure the surgeon got a little bit nervous and stopped, and it's almost always the case. But in any way, what is your salvage procedure? Do you go back to another Heller myotomy, Min, or do you do pneumatic dilation? Do you do a poem? What is your salvage procedure? And then, John, I'll ask you and we'll end there.
Yeah, so if the manometry shows that patient has inadequate myotomy, it would be POEM after Heller and Door. I think that's probably the kind of the safest way for that
John.
patient.
We've had some success with pneumatic dilation in that case. It's usually just a little bit of sphincter or a little cicatrix around whatever sphincter was left. So we'll usually give that a shot. There's different data out there. As long as you're thoughtful, it's not going to burn any bridges, and then a poem.
Well, you guys are wonderful. Your experience is really valuable to all of us, and I really appreciate you both taking time out of your evenings, time away from your family to spend it teaching all of us. I can't thank you enough. I know you put a lot of time into preparing for this as well. I thank all of the attendees for being here as well. I hope that you learned something. Remember that CME is available, and we look forward to the next AFS-sponsored webinar. It's been a great night. Thank you all, and we'll end it there. Take care.
Thanks, everybody.
Take care.